Good evening, ladies and gentlemen. My name is Colin Woodhouse. I'm chair of the Unitarian Universalist Shelter Rock Forum. And this is what we are holding tonight. Part of what our function, our goals are as a forum is to bring in notable speakers who can discuss cultural, ethical, moral issues of importance to our society in this day and age. Stephen Blake came to us and said, we need to do something and bring our notable speakers from the localities, from our towns, to talk to the people and discuss what's going on. And we all thought that was a wonderful idea. And so this is another iteration of the Shelter Rock Forum, where we discuss local issues, issues of concerns to communities, to you as individuals, and to us as ethical, moral, and compassionate people. So again, I'd like to welcome you here today. Can I ask how many of you have ever been to our congregation? Can I see by a show of hands? Okay, great. We're kind of tucked away up on the hill here. We have 100 acres. We've been in existence for almost 30 years now, I think. And we have several core principles that we adhere to. One is the inherent worth and dignity of each and every person. We believe in the interconnected web, that what we do or don't do has an impact that can be lasting on other people and ourselves. We believe in democracy. We run a democratic congregation, and all our decisions are done in the use of democracy. We also believe in justice and compassion in world affairs. So you'll see us out there marching, you'll see us out there demonstrating, you'll see us funding grassroots organizations that lift people up and fight for social justice. I urge you to take a look at some of the work that we're doing. Come on in and see some of our programs. Come on in and be part of what we're offering. We love to meet folks from the community, and we want to get you up to these beautiful grounds. It's 100 acres. To me, it looks like something out of Virginia. So don't keep it a secret. Come on in, the door is open. Okay, so no further ado, Stephen, I'll pass it over to you.
So I'd like to introduce our guest today, Michael Dowling. He is the president and CEO of Northwell Health, New York's largest healthcare provider and private employer with 23 hospitals, more than 665 outpatient locations, $11 billion in annual revenues, and more than 66,000 employees. Prior to joining Northwell in 1995, Michael served for 12 years as Deputy Secretary for Governor Mario Cuomo and as Director of Health and Human Services. So I'd like to move right in. I just finished, and I see some people have it, reading a book, Healthcare Reboot. And in it, Michael, you talk about being optimistic. So my question is this: healthcare spending is more than 18% of the economy and will grow to 19.7. But the US ranks last overall among 11 industrialized countries on measures of health system quality, efficiency, access to care, and healthy lives. There's a threat to the Affordable Care Act filed by Republican state attorney generals and by the Trump administration, and the cost of drugs is very high. So why are you optimistic?
Well, first of all, some of the international comparisons you have to be very careful of. That's another topic we can discuss. But why you're optimistic? First of all, you've got to look back historically and just think about where we were and what we could have done and not done 30 years ago. And you look at the history of the development and the success of healthcare over the last 30 or 40 years, it's extraordinary. Where people are living 35 years longer today, than they lived less than 100 years ago. In the 1970s, if you had a heart disease, there was no treatment for you other than being told to go home, put your legs up, and rest. You had a 40% chance of dying. Today, we can, heart disease, death from heart disease has gone down unbelievably, in an unbelievable high rate. The same with stroke. You take any of the areas, take stroke, take neurosurgery, take orthopedics, take cancer. Just look at today with the survivability of cancer. So obviously things were cheap back in the 1960s and the 1970s because you couldn't do much. There wasn't much treatment. Look at it today. Now you can argue that we spend a little bit too much money than we should, and I would agree with that. But the progress of healthcare over the last 30, 40 years, and the things we can do today that we could not even imagine doing 30 years ago is extraordinary. That's a positive story. And the trouble you have is that everybody looks at the negative, the downside. The cup is always half empty. I happen to like to talk about how the cup is half full while acknowledging the things that need to be fixed. And if you look at the science and the developments and the things that we'll be able to do tomorrow and in the next 10 years based upon all of the technological advances that are going on today, all of the medical advances that are going on today, it is pretty extraordinary. So that's why I'm optimistic. Healthcare has been a phenomenal success. And if you understand the history, it is hard to come to any conclusion other than to say that we've come a long way in a positive way, and going forward, I think it will actually even be better.
How then do you, or how do you explain a couple of things? Number one, measures that are taken that compares a variety of different health measures compared to other, mostly European countries. And the fact in the last 3 years, multiple years, life expectancy has actually gone down in the United States.
Well, yeah, but you look at things over a trend. You look at things over a longer period of time. You don't take a one-year little thing and say there's a little dip. It's just like your income over, if you're a family and you have income over the couple of years, and 1 month it goes down, you don't basically say things are bad because of the 1 month. You look at what has happened over the last 2 to 3 years and see the progress. And on the international comparisons, I'm very familiar with the international systems. I just came back from Europe on Sunday. Mm-hmm. As you can tell, I'm Irish. I'm chairing a commission in Ireland. They spend much less money, but you will wait 3 years to get care. It is extraordinary. The things that they are tolerated over there, you wouldn't accept here at all. Everything is done in a hospital. There's no outpatient ambulatory care. Everybody has insurance coverage, but access is limited, much worse than here. Mortality stats, a lot of the death stats that they show in this country, they include in it death from car accidents, death from gunshot wounds, injuries from gunshot wounds, have nothing to do with the healthcare system. So you got to be very careful when you make these comparisons. Now, there are good things happening overseas, but I can tell you from my experience in England, in mainland Europe, in Ireland, despite some good things happening, I will take the system in the United States over any one of them. And I think we should be proud of that while acknowledging the things that need to get fixed. When I was in Dublin last Friday and Saturday, and I was looking at a list of people waiting for surgery for 3 years. They don't count the fact that you're on a waiting list until after you've been waiting for 2.5 years. It's easy to have your numbers look good when you have a situation like that. This is my own country. This is where I grew up. A lot of the academic people who do these analyses, they look at it from a complete academic world. It's like a classroom. We sit in the classroom and do the numbers. You've got to go into the ground and find out what's really going on. And that's not being apologetic about the things that are going on here that should be improved. I'm not saying that we don't have problems. We do have problems. But I left Ireland with a whole other group of people that I took over there with me from other parts of the world, shaking my head, thinking, this is the system that the United States want to move to? Because there's this big argument these days about single payer. That's a single payer system. We go into, the facilities are in bad shape, et cetera, and I could go on, but I won't. So we have our issues, but I look upon the progress that we're making in this country as being pretty phenomenal.
Well, let's discuss a little more the cost.
Yeah.
So, is there an opportunity to save money and
Yes.
to do that? And if so, where would you be able to do that?
The best place to save money and to improve health, overall real health, other than medical care delivery. Remember, let me make one distinction. Medical care delivery is not the same as health. Medical care delivery is a component of health. Health is a broader issue. Medical care is a component of it. So you want to improve healthcare status and healthcare cost? People's lifestyle, what they eat, nutrition, well-being, exercise, childhood obesity, smoking. That's where you save money on healthcare. When people ask me, who should be reforming healthcare? Quite frankly, if we're honest with ourselves, it's each and every one of us in this room that should be reforming healthcare based upon what we do for ourselves. That's where the big cost over time will change. When I have to fix the waiting room in a children's hospital to get chairs double the size of this one to take care of obese 12-year-olds, which we in the health system didn't create, that's an issue. So, and this is what, at Northwell, one of the things that we're trying to do more and more over time, and it's slow, is to move upstream and to deal with problems before they occur. So, health is about wellness, lifestyle, behavior, the prevention of illness, and then the treatment of illness once it occurs. The medical care system, and what I get primarily, what Northwell gets paid for primarily, is to treat you after you get sick. What we have to be doing is going upstream to deal with things before you get sick. And we all have that responsibility. A couple of other issues to broaden the discussion. You go in, and all of you have been in this situation, you go into any grocery store, or home, the Grand Union or whatever, and you walk into the aisles. What do you see on all the front aisles as you walk in? All of the stuff you should not eat. All of the sugar. All of the things designed specifically to get you to buy them for their kids, all of them not good for you. The industries that promote that are promoting indirectly a culture of illness. And yet when you go and buy all of that stuff, and you use it, and you end up with diabetes and other things, and you come into the hospitals and the docks, and then the health system is blamed for it. Now, there's a lot of stuff we need to be blamed for. There's a couple of other issues. We over-test people. We do too many procedures on some things sometimes. Sometimes we do too much surgery that shouldn't be done, and that I know of in the health arena across the country are working on trying to reduce that over time. One last thing. There's a lot of things, so I just thought of this one. Go home tonight and watch television, and within 15 minutes you will see medical technology being advertised and drugs being advertised. If you watch television for more than half an hour and you're not taking one of the drugs that are advertised, you think there's something wrong with you. Okay? In Europe, they don't advertise drugs. Okay? We've consumerized it. It's making it open to the public. General Electric, country we do work with, they like to sell, diagnostic equipment, MRIs, CTs, PET scans. Their business model is based upon selling us more stuff than we probably need. And when we hold focus groups with people out in the community, and we say, how would you judge a great hospital? They say, the technology you've got. Sometimes the technology is not necessarily all that good for you. A lot of it is good, but overuse of it is not so good. Healthcare is the point I'm trying to make is a very complicated issue. We have to do better at prevention and wellness. For example, I did say it would be the last thing, but let me mention it. In our organization right now, we're spending an awful lot of time trying to focus on the food that our employees consume in our organization. Healthcare employees are the least healthy of any group of employees in any business, which is an unbelievable irony, given the fact that that's the business that we're in. So, for example, we've hired there a year ago a Michelin star chef. He had been the chef at Plaza Hotel for the past 14 years. He's brought in other Michelin star chefs, and we're trying to change the food that we deliver in the hospitals. Like, over time, get rid of all of the soda drinks. Over time, get rid of all of the French fries. I got to tell you, if you need a revolution, try to get rid of French fries. I mean, people are screaming at me, we need help, we need help, we need help, but please give me the French fries. And so we're spending a lot of time on that, also spending a lot more time on employees with regard to wellness. And so we got to make much better use of nutrition. We've got to do a lot better in education. The American health system has not done a great job on this area, but neither has the systems overseas, by the way. But that's one of the ways. There is other inefficiencies in the health system that we obviously got to work with. But.
What about, I mean, within, and you mentioned in your book, and actually you're an advocate of a change, but fee for service,
right,
as a model in this country, which I think you mentioned tends to lead to a lot of different expenses. Can you discuss that and what the solution is to that?
The way there's no perfect solution, by the way, in any of this, because every system you come up with has a fault. But the way we typically get paid in the United States is what's fee for service. You come in for a procedure, we get paid for the procedure. You come in for a shoulder, we get paid for the shoulder. You come in for a big knee, you get paid for the knee. You come in for a pulmonary issue, we get paid for the pulmonary issue. And it can lead, and has, as has been proven, that it does lead to sometimes overuse of care because of the way you get paid. For many, many, many years, and still to a great extent, we got paid more if you were in the hospital, and got paid hardly anything if you were not treated outside the hospital. So one of the things that we've done in our system, and we took a big financial beating on this for many, many years, is we've moved a lot of services from in hospital, out of hospital. So most cancer care, for example, is outside hospital today. Over time, most orthopedics will not be done in a hospital at all. 90% of it will be done off-site, like we're doing 50% of our orthopedics today is done off-site. Imaging should be off-site. And making those kind of changes about where it is you deliver care helps to reduce the cost. The other way you do it is and this is going on right now and has been for a couple of years, you experiment with different ways of getting paid. So the model that I like, even though it has a downside, is that I get paid a certain amount of money per year to take care of you. It's called, I don't want to get too technical here, it's called global payment, right? Or capitation is another word that is used, or bundled payments. So for example, you're Mr. X, I get a certain amount of money to take care of you. My incentive now is to make sure you stay healthy. If I get paid every time you get sick, my incentive is to do more with you. And that's typically the model. So the fee-for-service model forces you sometimes, creates incentives to do more than you should. On the other hand, you've got to be very careful with a capitation global model that you shirk on what it is you give people, because you decide that you do much less than is needed. So either one, there are downsides and positives to each. I tend to like to move away from fee-for-service over time into kind of a global capitation, and we're doing that at Northwell. To help us with that regard, I started an insurance company. I had an insurance company. We were doing very, very well. It grew phenomenally fast. The whole idea behind it is that I get paid a premium to take care of you. That my incentive is that I want to make sure you're healthy. I don't want to have you getting sick all the time because I lose money when that happens. I had to close the insurance company because there was a part of Obamacare that was ridiculous. and that made it impossible for companies, a new company like the one we had, and many other companies around the country to survive. They added a technical aspect. It's called a risk adjuster. The bottom line was that for every premium dollar I was collecting, I had to pay 45 cents of the premium dollar to United Health. Because on the assumption being if my employees were healthier than my members were healthier than the members that were being taken care of by United. Problem, of course, is when you're a new insurance company, at the beginning, everybody that joins you is healthy. You only know what their disease state is over a period of time. And the methodology that the Obamacare people used was all screwed up. It meant that I could not sustain maintaining the insurance company. But I'm going to find another way to get back in, to move in that direction. That's the right way.
You would like to have an insurance company again?
Yes.
What would be necessary for that to happen?
Well, first of all, since once you close it, the government won't let you get back in for another 5 years. And then you got to make sure that some of the regulatory stuff that government puts on you are not onerous, so that you can actually do good stuff, but also not go broke doing it.
Now, you mentioned that one of the inefficiencies and expenses of the system is that you're employing that something like 40% of your claims are rejected, that you have hundreds of people that are actually fighting with the insurance companies in order for the hospital to get paid?
Yes, this is something that people don't understand. Because healthcare, I don't know if there is another business that is as complex as healthcare, just let me state that. And anybody that has ever gone into it and have spent any time in the healthcare space realize that this is way more complicated. And I love it when people say to me, I run a hotel. Well, I don't run it like a hotel. Yeah, people check in and they're on their own until they check out, right? So what happens is you come to us, you have insurance, let's say. You come to us and we have to get pre-approval from the insurance company, which is a bureaucratic mess. Then we provide the services, so you need open heart surgery, you need a hip replaced, or you need a shoulder done or whatever, and we'll do it. Now I don't get paid. The insurance company will typically deny payment for about 27 to 30% of what we do. I've already delivered the service. Because their business model is make money by not paying the provider who already delivered the care. So you get a 27 to 30% denial rate. And I now have to have a whole staff of people trying to figure out how to get paid after I deliver the service. So let me give you a number. I have 4,000 people working for me who do nothing but try to get paid from insurance companies after I deliver the service. And they, on the other hand, probably have an equal number of people trying to make sure that I don't get paid. Now, over the course of a year or 15 months or 2 years, we'll get paid some of it. It's the float. So they hold on to the money every quarter. You always know when the quarter numbers are coming up because the denials go up a bit because you know that they're trying to show better quarters. I, on the other hand, am sitting there thinking, hey, I need the money. I already delivered the service. That is an inefficiency that has to be taken care of, and we're working with the insurance companies on this. It's a slow process, it's difficult, but we are being very, very aggressive on it.
Isn't this an argument for some of the things that are being proposed in the presidential election? You're talking about Medicare for all, or the public option,
right. Now,
or you're talking about single payer. You have all these variations.
Sure.
Isn't this one of the issues that is cited here, is the fact of this profit motive, raising costs and getting in the way of health care?
Right, that's an argument, but now you got to look at the opposite. You want government running healthcare? It doesn't work. It hasn't worked anywhere.
What about Medicare?
Medicare, if you are a hospital and all you get paid is Medicare, you're in big trouble. If you're a hospital and all you get is Medicaid, you're underwater immediately. because you don't get paid enough to meet the cost. And the regulatory apparatus is so all-consuming, and micro-regulation is extraordinary. We have single payer in the United States. So let me give you a couple of examples of single payer. The VA is single payer. Nassau University Medical Center, NUMIC. You have the public hospital here?
Right.
That's single payer. I decided to go in to help them, and I put a team of people there to manage it. They started about a month ago, because I believe we should do the right thing to help people as much as you possibly can. But Nassau University Medical Center loses so much money, it is unreal. They're single payer, government pays, it's 95% Medicaid, a government payer. They're a union hospital. Their expenses are here, their revenues here. In Brooklyn, I'm working with 3 hospitals in Brooklyn. Brookdale, Kingsbrook, Wyckoff, Interfaith, 4 hospitals. Between them, they're losing $300 million a year. They're single payer. So you have to be very, very careful.
So are there any systems that you're seeing, is anybody on the right track in terms of doing say a public option is one of the ideas that was presented by Hillary Clinton at the time Obamacare was done, which was the idea is fine, let there be private insurance companies, we'll give people an option of using Medicare.
You have to have a mix between public and private. Public system will always be huge because remember, Medicare is going to go up as a percentage. Medicaid is increasing. In terms of the number of people covered by Medicare, there's no alternative because of the demographics. 12,000 people turning 65 every day. So Medicare is increasing. Medicaid is increasing as well. So government will have a big, big role. So it's a combination of the government, and one of the things that I would hope that we do is figure out how do you cover those people that are uninsured without dismantling the whole apparatus of the whole health system. And you have a public-private compromise, a public-private relationship. The trouble you have these days is that there's so much partisanship. Everybody's over here on one side and everybody's on the other side, and nobody's coming together to figure out how actually you take the best of each. So it's a combination. A public option is a possibility. If there was a logical discussion about people wanting to sit down from both sides of the aisle and say, we're trying to solve this problem, but nobody's trying to solve much of a problem anymore. It's all about how do I play to my constituency base? How do I make myself sound good on TV or play to the politics without sitting down? Nobody's actually talking. So, but it is a public-private combination. And there are solutions there. The insurance companies need to be tightened up a little bit. But believe me, I would much rather deal, as bad as an insurance company is sometimes, I would much rather deal with an insurance company than deal with government. I can fight an insurance company, I can't fight government. Mm-hmm. When government makes a decision, where am I going to go? You can't. And I'll give you a little example. I mean, there's bureaucracy every place. We're all involved in bureaucracy. There's bureaucracies in churches. There's bureaucracy in every business. It's part of the course. But recently, at the state's request, they wanted me to do something. Within a day, I decided to do it, and I gave them the proposal. It took them 5 months to agree with it, even though it was something they asked for that I gave them. You can't operate like that in the business. It just doesn't work. So I'm not for moving towards the full public option. Another great example in the city is NYCHA, the housing authority in the city, public housing. I mean, it's a disgrace, an absolute disgrace. And in Ireland and even in England, the English system, by the way, everybody says the English system is wonderful. There's some good parts to every system, so I'm not generalizing it completely. I've had the English system over here looking at what we do to see how they can take the lessons from what we've done at Northwell to see if they can apply some of them over in London. So everybody is trying to search for this magic cure.
Let me ask you this in terms of another issue that at least has been stated. The idea that hospitals and doctors practice defensive medicine because of the fear of being sued and medical malpractice. How much is that real? That was always cited as, lawsuits were always cited as one of the reasons as being a big driver of healthcare costs.
It's a driver, but not a huge one. It's exaggerated. That way. Is it a problem? Yes. But we should have malpractice reform, but it is not the big issue that some people make it out to be, that if we solve that problem, everything else would go away. I don't see that. I don't see that at all.
Now, what about the cost of people without insurance? You are required under law.
We take care of everybody.
Right.
So there's nobody turned away from our health system. Now you get your access now through, for example, a lot of our urgent care centers. You get access through the emergency departments. If you come in and you need something and it can cost tens of thousands of dollars or hundreds of thousands of dollars, we will do it. Not everybody does that, by the way, even though there are laws on the books that says you should do it. There are always around it. We don't go around it. We do it. We take care of people that have a need, irrespective of whether they can pay or not. And then I have to figure out how to eat it, deal with it over time. That's part of the mission.
How big in expense, and does this lawsuit that was filed by the Republican attorneys general, that was backed by the Trump administration, where they're trying to overturn the Affordable Care Act, is that something that is worrisome to somebody who's running a healthcare system?
Oh, yes. I mean, it's very easy to knock down something. It's a lot tougher to figure out what you put in its place. Any idiot can knock down something. It takes no smarts to say, I don't like that, because the person I didn't like created it. Therefore, I'm going to go in with a sledgehammer and a bulldozer and knock it down because we have something so much better. Where is the something better? There is no alternative. It needs to be fixed. Are there things in Obamacare? See, the smart thing to do, if people were logical, you'd say, okay, Obamacare it did good things. Don't get me wrong. It covered an awful lot of people that weren't covered before. It was moving the trajectory for more and more coverage. It had some things in it that were problematic. So what you sit down and you say, okay, I'm going to fix that which is broken, and bring in some of my own ideas into the mix, so that at the end of the day you have something that we can both sit up in front and say, this works. It's like you have a house and you want to change the kitchen. You don't knock down the whole house because you want to fix the kitchen. You fix the kitchen, you keep the bedrooms, you fix the kitchen, you put it together, and you figure out how to make it work. But this thing that's going on in Washington at the moment is nonsensical. It's ideological to an extreme. It is stupid in its extreme. And it's insulting to people's intelligence. Because I don't like the guy that was there before, I'm going to knock everything down that he ever did. Because if you look at not just in healthcare, and I don't want to get overly political here, but almost everything that was touched by the previous administration, this administration wants to get rid of. Why? Because you didn't like the guy that was there? You don't like some of the things he did? Fine. There's always disagreements. Fix them. Don't knock them down, especially when you don't have a clue about what you want to put in this place. Not a clue. And I'm very close to some of these discussions. There is no alternative.
What if this lawsuit actually is successful, and Obamacare goes away 6 months from now with a lawsuit?
You have another 20 million people without insurance in the United States.
And what does that do to the healthcare system?
To us?
To life expectancy, to coverage overall health?
I think over time it's really problematic. We're better off in New York than elsewhere, because in New York we didn't benefit from Obamacare in New York like other states benefited, because New York has been traditionally more progressive. We've had fewer and fewer uninsured in New York. There should be no uninsured, let me make that clear. But we had much fewer uninsured in New York than other states. In other states, it was pretty horrific. So when Obamacare came in, those states used Obamacare in those states, covered lots of these people. If it goes away, New York will get hurt a little bit. Those other states, and some of them even voluntarily today, are deciding that they want Obamacare, and they're willing, for political ideological reasons, They're willing to say, I don't mind if 2 million people in my state are now without insurance going forward. They're willing to make that trade. I think that's the height of ridiculousness.
Now, let me ask you, backtracking a little bit to the life expectancy, there was an interesting part of your book. For those who haven't got it, it's titled Healthcare Reboot, available in bookstores across the country. In it, you mentioned that for life expectancy, you put healthcare at 10% of the impact on people's life expectancy. You had individual behavior was 40%.
Yes.
Genetics was 30%, and social environmental 20%. Discuss that a little bit.
Well, that's what I talked about a little bit earlier.
Right.
This is part of the problem is that they look at the healthcare system, meaning the medical care delivery system, as being responsible for everything.
Well, you were mentioning that also that Europe spends a lot more on the social security net, the social net,
Right.
In things like food, housing,
Sure.
non-medical factors, transportation, parks.
So-
How big a factor is that in your mind? Those sort of things.
Yeah, the whole social safety net, which some of the European countries have a much more extensive effort than the United States. In fact, when you include their social safety net expenditures with their health expenditures, that overall cost is not that different in the United States. Because we're not comparing apples to apples when a lot of these people make these comparisons. So the social issues, the lifestyle issues, the behavioral issues, this goes back to what I said at the beginning. If you want to improve health, overall, we've got to fix the medical side of the business, right? Mm-hmm. But we've got to really work on the other side. You are never reducing the cost of healthcare in the United States, ever. You are going to reduce the rate of increase.
Why will we never decrease it?
Because the demographics are running absolutely against you. The growth in the aging population, which is where the bulk of the cost is, most healthcare costs are at the end of is for people over the age of 75, 80 in the last year of life. That's where the bulk of healthcare costs are. Healthcare costs are not spent by the 35-year-old. That's not who spends healthcare. This is why when you hear stories like Amazon, Berkshire Hathaway, JP Morgan out there saying that they're going to resolve the whole healthcare problem. Yeah, and I know these people. I think that's fine that they're involved trying to do something, but they're looking at their employees, mostly middle-aged, less than middle-aged, 30, 40-year-old people who are relatively healthy anyway. They don't spend any money on healthcare. That's not where the expense base is. So the big, let me put it another way. Part of our problem is that because we've and this, some people don't take this the wrong way, but part of our problem is that we've been too successful. The ability to keep people alive a long time adds to the cost. And as you live a long time, more diseases show up, like Alzheimer's. Alzheimer's is a function of the success of keeping people alive a long time.
I used to be in favor, when I was young, I was in favor of putting the old on ice floes, but as I've gotten older...
I would never say that in an audience like this.
As I was getting older, I've begun to change my opinion on that as a solution.
But now the other part of this issue about the cost is there are new technologies coming out all the time about what we can do in the future that we can't do today. So for example, a lot of baby boomers in this room. Many of you remember years and years ago when people had a bad hip. What was the attitude? Suck it up and take care of it. Today you have a bad hip. I can change your hip in 38 minutes in our operating rooms. 38 minutes. So because we know how to replace a hip, we replace more hips. It's cheap when I say, suck it up. When I say, I'm going to replace your hip, there's a cost, okay? Now you can argue, maybe what people pay for the hip should be a little bit less than what it is. That's another argument. But looking going forward, what we'll do with neuro, or with what we'll be able to do with the brain in the future, what we'll be doing with wearable devices, with implantable devices. The ability, for example, for people to be self-monitoring their own health, which is very good to help them improve over time, but the more you self-monitor, the more you find out that's wrong. Everybody here, let's just make this assumption, everybody here right now thinks that you're relatively healthy. You're only healthy because we haven't diagnosed you yet.
Let me ask you, on the question of medical errors had been a very big problem. The number of people who die
Sure,
in hospitals because of hospital error. How big a factor is that, and what's being done to lessen that?
Hospital errors.
The idea is that it's dangerous to be in a hospital.
Well,
Or at
first
least
of all, let
some
me put it
people
this
think
way. Hospitals are great places to be if you need to be there. They are not good places to be if you don't need to be there. This is why we have taken more and more of the services that used to be in our hospitals outside the hospitals. That's why we have 735 non-hospital locations today. So you're much safer to get care outside of a hospital if you're not chronically seriously ill and you don't need all of the machinery and the tools that we have in the office, in the hospital. So there's been, every statistic has been going down in terms of infections, sepsis, etc. Now, ever so often things blow up, like recently we have this new thing now that we've had some cases in the hospital recently, this Candida auris, this new, like that new bug, where we've had some cases on this recently. Because everybody's on so many antibiotics, the body develops a resistance to it, and so they don't work like they used to work in the old days because the body has a way to react to all of these new things. The other problem in the New York area, in the Northeast United States, with hospitals is all of the infrastructure is old. Most of the hospitals, not just ours, except for all the new things that we've been building, and as you all know, we've been building a lot of new stuff, most of the hospitals have double rooms, triples, and quads. Most of our hospitals were built in the 1920s, 30s, and 40s. North Shore and LIJ were built between 47 and 53. Staten Island Hospital, which is ours, was built in 1860. Original hospital was 1861. Lenox Hill is the 1850s. Now, if we'll put two sick people with infection in the same room, you have a problem. You can go to some parts of the United States where you will never see a hospital except single-room hospitals. And people think it's just for privacy, which is important. And everything we build today, everything new, is all private rooms. Privacy is important, but you know what the real reason is, going to your question? Reducing the possibility of transmission of infection, where you can isolate in a single room. Our infrastructures are not like that because we got old infrastructure.
As a consumer,
yes,
how do I ensure that I have the best experience when I go to a hospital? Or what are the tips for going in to make sure that I'm going to be diagnosed correctly, that I'm not going to contract something when I'm there? Is there ideas that as consumers that we should bring with us when we go to a hospital?
Or that you don't bring something into the hospital, which is the other problem. Remember that this isn't often caused by hospitals. This is often caused by people coming into the hospital with it. And then they'll complain that we gave it to them after they come in. So it's a double slope. Best thing to do is to be as knowledgeable as possible. If you have a private physician, develop a very close relationship with your private physician. Most healthcare is delivered by nurses, by the way.
Mm-hmm.
Develop great relationship with the nurses. Nurses are key. But there's so much information available these days, but you've got to be careful with some of it too, because there's a lot of information on the internet that is not the right information. It can throw you off completely. So I would say educate yourself as much as possible, network as much as possible, find out if you're going to see Dr. X for surgery, check around to see whether or not what the record of that person is, what other people say about him. Check with the nurses in the hospital about that physician if it is surgery. But remember, people don't, bad things don't necessarily happen too often in surgery. It's post-surgery it happens. But I would say that to get as educated as you possibly can, make the contact, develop the network, get to know your physician well if you have a physician. Remember, everybody has a physician. A lot of people have a physician Monday through Friday. The physician on the weekends is the emergency room. So there's this idea like I have my private physician. You do, except Saturday night. So don't get sick on a Saturday night. You're going to the emergency room. Now, emergency rooms, people will wait sometimes. This is why we built all these urgent care centers. Because when you go into an emergency room, if you're not very, very serious, there might be very serious stuff going on, and you'll wait. And that frustrates people, and we're trying to get better at that. And the amazing thing about it is no matter how big you build an emergency room, it gets crowded immediately. We have doubled, tripled the sizes of our emergency rooms, thinking there will never be a case where this emergency room will be packed. A month after we open it, it's packed. It's amazing. There's one other thing I just want to mention here is technology. If you look to the future, a lot of the doctor appointments will be through this. It's happening today. So in the future, you'll be able to do the initial diagnosis with the doc on this or something like this. So you won't be going to a bricks and mortar facility like you do today. You'll have wearable devices. You'll be self-monitoring. We will monitor you from a distance. You can be at home, and we can bring a hospital bed to the home instead of having you going to the hospital. That's all happening today. We have the largest telemedicine technology-assisted services of any place in New York right now. We do a lot of psychiatry testing, for example, through telepsych. That's the other thing, by the way, that I should mention, that the issue, the opiate issue, the behavioral health, mental health issue is becoming a huge problem. And we are one of the largest providers of mental health. That's another huge driver of cost, by the way. The combination of the physical health and mental health and substance abuse is becoming a huge issue. This is something we struggle with all the time.
Two final questions before I let our attendees ask you questions as well. One is, we've discussed how big, how many hospitals, how many physicians, how many people. Is all that a good thing? Because in this country, we're talking about private enterprise and competition. And Northwell now represents a very large share of healthcare services all the way down the line. Is that a problem? Should there be more competition? Are we losing something with that?
I would say it's a good thing. Now, don't think that there's no competition. There is much tougher competition today than ever before. The world has changed. So who's the biggest? Let me give you the competition today for me, from Northwell. Columbia Pres, Mount Sinai. I'm the biggest player, but these are big players too. Mount Sinai, NYU, Montefiore up in the Bronx. Now there are others. CVS is getting into the healthcare delivery business. Walgreens is getting into the healthcare delivery business. Amazon. Google, all these private equity players, venture capital guys, all over. You don't have to travel far from this location. See it. Now, people will say you got very, very big, and therefore do you have too many hospitals, et cetera, and did you just get big for the sake of getting big? So let me just talk about that for a second. Remember, in New York, downstate New York, over 30 hospitals have closed, which is often forgotten about. Over 30 hospitals have closed. The government talked about closing hospitals, or the market closed hospitals. Competition closes hospitals. Now, some hospitals that were doing in very bad shape, that were in very bad shape, we preserved. If it wasn't for Northwell and the fact that we grew, Southside we protected from dying. And Southside is a great place today, serving a huge community. That hospital would have closed. Plainview would have closed. Glen Cove would have closed. Syosset would have closed if it wasn't for the scale and the system, this effort that we would have. I was able to take money from North Shore University Hospital, which was doing well, to finance for many, many years the massive losses at Southside and Plainview and Syosset and Forest Hills and Valley Stream, Franklin, etc. So we protected the local delivery of care in those communities that without them, those communities would be in very, very bad shape. Okay? Now, there are no two systems, health systems in the United States, the same. We're all different. I like to think of us as being better than most and doing a better job than most. We're very integrated. I do not believe, I object to people just building up, taking over multiple facilities and not integrating them. In other words, not combining back office functions, not trying to be efficient, not developing common standards and protocols and common quality outcome metrics, etc. There are systems like that around the country that just collect, become large, and don't create a company that actually works. I'm able to maintain, I'm now one of the largest providers of mental health in New York State. Why? Because I can take the assets from the other places and support mental health. I do a lot with veterans. I'm able to support veterans that I couldn't do if we didn't have a system like we currently have. I hire 500 veterans a year. Any employee of ours that is deployed in the military, I maintain their full salary the whole time they're away. Okay? So we provide an enormous amount of services all over the place that could never have been done by an individual hospital if they hadn't come together as a group. I think we do it right. That is not to say that there are not systems around the country that don't do it that way, okay? Mm-hmm. But the big places in the United States, the ones that I spend a lot of time working with, like Kaiser Permanente, Intermountain in Utah, Providence on the West Coast, et cetera, Geisinger in Pennsylvania, I got to tell you, all of these people have the right motivation. They're going the right direction, making massive improvements in how we provide access and care. Not perfect. None of us can say we are. There's no organization anywhere that is perfect. You can always find holes in anything, but I think we have the right motivation and the right desire to do the right thing. So I think it's been a good thing overall. If you're an individual standalone hospital today in New York, in downstate New York, you are dead. You cannot survive. The insurance companies, which are the ones that pay you, the non-governmental part of the money, including some of the government. I remember when I came to North Shore Hospital way back in the 90s, there were like 30 insurance companies around here. Today there are 3 big ones. They're all national players. If I'm not strong enough to deal with the big national players, I'm in big trouble. If I'm a single hospital, they can just they can kill me tomorrow morning. It's hard for them to do it to us now. I can preserve services to the community because I can stand up in front of them and say, okay, you want to have a little bit of muscle? I have a little bit of muscle. And by the way, I have a group of people that do nothing every day but sit across the table from insurance companies negotiating payment. It's a constant, ongoing, I have a whole department, that's all they do every day. If you want to have a miserable day, spend time with them.
So my final question before we allow our attendees, as advertised, ask their questions. And this, I'm taking a page from a town hall that we had, a community forum that we had a month ago. Other than the obvious first answer, which is yourself, what is the role of immigrants in the Northwell health system?
Well, you get me started on my favorite topic. First of all, immigrants created the United States, number one. We're all immigrants. We should never forget it. Every single one of us in this room is an immigrant. We may have come in an earlier boat, but we're all here. And so this is something to keep in mind as we deal with all of the current discussion. And anybody that has ever understood the history of immigration knows that some of the stuff that's going on today, even the debate, even the language, is something that went on 50 years ago, 100 years ago, 200 years ago. History repeats itself over and over and over again. Immigrants in our health system, I mean, if you're talking about employees, I love them. You know why?
Why?
They work hard. They have a desire. I'm an immigrant. I came here. We get the problem that we have, we're getting, the part of the problem that we have, and so you got to be careful the language you use here, but when we're a very fortunate country. I mean, there's no better place in the world than here. I came from a very poor family. I came in, I was 17. I started working on the docks, worked in construction. I came here by myself. I'm standing up here now talking to you about running the largest healthcare company in New York State. This could not happen anyplace else, okay, except here. Okay? But those of us that here, and we have kids and grandkids, we got to instill in them that desire, that grit, that immigrant desire and grit, that sometimes over time people lose because people get too comfortable. Things bother them that which never bother me, or most immigrants. When I meet all new employees that are hired in the health system, we hire 180 people a week. I spend 2 hours, 2.5 hours with them every Monday morning. I meet every new employee. I've been doing it every Monday for 14 years. I often ask, how many people in the group, first generation? And the more hands that go up, I know I'm getting productivity. They're willing to dig down. They have that inherent desire. They'll put up with annoyances that other people complain like crazy about, little annoyances that nobody should even worry about, right? They go for it. We can't lose that immigrant desire, okay? And when we lose it, you get complacent, lazy, complaining, you don't have that edge. I'm a little old-fashioned on this. Keep that edge, keep that grit, suck it up. Things happen, you had a bad day, get up tomorrow morning and say, the heck with it, I'm going to make to follow a better day. Stop complaining. We have too much complaining going on.
Well, thank you very much for answering my questions. I'm now inviting people to come up or raise your hands, and we'll bring you the mic. Before we ask the questions, my one request is ask questions. Let's keep the speeches down and the questions up.
Hi, my name is John Santakis. I work in the healthcare system at Elizabeth Seton Pediatric Center. And you struck a chord when you mentioned the disappointment with the current administration. And I look at Obamacare as a moderate Republican system. It was something created similar to Romney Care. When the new administration comes in, what is your wishes? What are your 3 wishes that a new administration that actually does care for healthcare do?
A couple of things. One is to decide that, because you can take hold of a whole, you can grab a problem in its totality. Sometimes it gets too big. I use the analogy I use like with eating an apple. You can swallow it and choke, or you can take a bite and move it and go forward. I would like to make sure that a new administration comes in and declares that my goal will be to make sure all children under the age of 18 have health coverage, all kids. Hard to argue against kids. I don't know how many of you know Child Health Plus, heard of Child Health Plus? That was something I started in the state of New York. I was involved in the passage of that. And it made a major progress. That would be, so I would take coverage, right? Get universal coverage. Everybody should get universal coverage and make it a combination of public-private in some way. But if you can't get the total package, go with kids. Because if you're interested in prevention, right, that's where you go. Second thing I would do is that I would dramatically reduce the volume of unnecessary regulation. Now, I'm not against regulation, don't get me wrong here. Right now, we have 1,700 quality regulations that we have to meet as you run a hospital. 1,700. It is nonsensically stupid. Pick 10. Tell me, for example, and I've been advocating for this, tell me, for example, I'll say to any of the providers, and we talk about this when we get together as big systems. We want you, and I don't mind the government saying this, we want you over the next 5 years to reduce the sepsis, infection as a result of sepsis, by 95%. But now get out of my way and let me do it, and if I don't do it, hold me accountable. But don't tell me how to do it every little step of the way, okay? I would, those would be two things that I would focus on. I would take the current system, like now I'm going beginning a little bit broader, take what we currently have and try to see where do we plug holes to make it better, but not tear the whole thing down. Just plug the holes. And with the goal of getting to a point where you can increase efficiency, increase productivity, get better access. We have a real problem, by the way, in the rural areas. You go upstate New York, there are no OBs upstate New York. So that has to be dealt with. We're very lucky around here, right? The argument down here is that we got too many docs everywhere, too many facilities. Now you go upstate, you have a real problem. So the whole rural area, if you're thinking globally about this, the whole rural area is an area that needs to be focused on an awful lot. But big policy changes are incremental. People love to go for the big thing and it just overwhelms you. Take it piece by piece and work it through. And that, I think, we'll make major progress that way.
I know that hospitals are rated, and years ago, I looked at something that said there wasn't one top hospital in New York. Massachusetts, Boston, Cleveland, Houston, all over, but we didn't really have one of the top hospitals in New York City or anywhere around. What does it take to be a top hospital? Do you do it? How are you rated now? Does it matter how you're rated, et cetera, et cetera?
That's a very interesting question. You have all these rating systems out there. Most of them are ridiculous. Okay, so everybody's rating everybody anymore. For example, I noticed today in Newsday, Leapfrog, which is a group that rates hospitals, and some of it is funny. Some of the hospitals were closed. Leapfrog rated them as some of the best, even though they were closed because they were bad.
They didn't lose any patients that year.
We don't participate with Leapfrog, yet they still give us a D, partly because we won't participate, because their metrics are all screwed up. They're just a measure. What does it become to be a very good hospital? There's three things. One is you have very good outcomes, which can be measured. Cardiac, for example. The one metric that is probably the best in the United States is the cardiac open heart metric designed by the state years ago. And they issue reports every 3 years. They look at every mortality and survivability of every patient. They're risk adjusted for severity. It is unbelievably empirically done well. That's probably the best. If you look at this New York right now, we probably have some of the best records in the United States. And I'm not saying this now because of what just happened. The stats just came out early last week. The top hospital in the city of New York for heart care is Lenox Hill. Yeah. North Shore, LIJ are way up there. Then you got St. Francis, okay? That is empirically sound. A lot of the other ratings, they go into databases in Medicare. They only take Medicare data, and they will they'll analyze data one way or the other, and they'll come out with A's, B's, C's, and we don't participate in a lot because it's ridiculous. So to me, you get the best docs, right? Especially if you look at surgery, for example. You get the best physicians you can find, and we're doing that. We recruit some of the world's top now. You get great nursing. You have unbelievably good customer service. Quality to me is about clinical outcome. It's about easy access and convenience and great service. I get letters from about patient care all the time, as you can imagine. Now, it's very interesting. I don't get letters from patients much at all. Patients don't write letters. Family members of patients write the letters. The husband, the wife, the son. When I personally respond to every letter I get. That's what I do all day, every Sunday. Okay? When there is a telephone number in the letter, I call the family. Yes. That personal touch makes a huge difference. And I do it because I encourage my people to do it, because the personal touch, you can have all the fancy technology, but let's be honest, you can't, and I'm afraid one of the things I worry about is that the technology will usurp the human aspect of care. You've got to feel like a VIP when you go in. The person who parks your car should be a good person, nice person. The experience should be great. This receptionist, the nurse, the doc, etc. So to me, it should be it's a combination of service, access, good quality outcome. And there's no measure that measures all of those at the moment. They're all measured separately. We actually have very good metrics. We do very, very well as a system. Not all of our hospitals do equally well, but many of them. North Shore is a great place. Lenox Hill will continue to be, right now it's also the #1 hospital in the city, in the United States for thoracic surgery. Best outcomes in the country for thoracic surgery. Now, people would not necessarily assume that. Cleveland is a good place because, remember, and I don't want to belabor it too much because I know I got a lot of questions, but sometimes hospitals have been around a long time and they advertise a lot. They advertise their brand, and people associate good brand with good outcomes. I can tell you in New York of places that have a very good brand that everybody thinks is the best place to go that have some of the worst outcomes in the state of New York. But people say, well, that place is good. No. Some places that pretend to be very good and market themselves as being very good have no metrics at all and will never share their metrics to demonstrate that they are. That's a whole area that needs to be improved, by the way. I do believe that it should be much more transparent than what it is. But we also, there's a lot of competition, but we also work together a lot. I mean, the clinicians and the researchers across all of the various places, they all work together. Memorial Sloan Kettering will send patients to us. We are the biggest cancer provider in New York. They'll send patients to us. We will send patients to them. The doctors will talk. We will compete. But when it comes down to an individual patient, you go together, as it should be.
Dr. Dowling, appreciate your idea of universal health care for children. My understanding is that even with the Affordable Care Act, there are 30 million people in this country who still lack health insurance altogether.
Right.
And I read about people who have to choose literally between prescription medication on which they urgently rely and groceries. I wonder if these realities jibe with your perception of reality.
Don't get me wrong when I say children. I mean, I do believe that we should have universal insurance coverage. I completely agree with that. Sometimes, though, the way the politics works, sometimes you pick a population that is part of that is easiest to get done, and you do it. And so sometimes with kids, you can more easily get something done quickly. But the goal overall of having everybody having insurance coverage, I'm completely for it. And I think it should be the top line goal of every administration. Unfortunately, that's not the case at the moment. Now, I understand one other thing. You can have insurance coverage but no access. They're not the same. People confuse this. In Ireland, let me go back to my own country. In Ireland, everybody has insurance coverage, but you don't have good access. You'll wait forever. I have brought so many people from Ireland and England over here that we have done surgery on because they're waiting for a year or 2 years. They all have insurance. So it's a combination of the two. But should everybody have insurance? Yes. But then you got to make sure that people have access to care, that it isn't empty insurance, and that they keep waiting lists and waiting lists forever. But I don't disagree with what the speaker just said.
Sir, right here, with his hands raised.
What percentage of total healthcare costs are due to drug costs? And
Drug costs?
What percentage of total healthcare costs are due to drug costs? And what can be done to control drug costs in light of recent stories in the news about generic drug companies colluding to prevent drug prices from dropping?
Yeah. You know, I think, I could be wrong on this number, I think it's somewhere around 12 to 15% in total. I could be off a couple of percentage points. The second part of your question is what should be done. The reason I'm hesitating because this is complicated stuff. The government, I think, has to take a very aggressive stand against the drug companies, especially those companies that raise the prices of drugs, you know, by 500%. And I've met some of these people. I know some of these people. I was in a meeting in the city at an event a year ago when the guy he's in jail right now, as he should be. He's a drug guy who ran a drug company, and he raised the price of a drug, I forget which drug it was, he raised it by 1,300% after taking over the company, which of course showed that he was making a lot of profit. And I will never forget, I was on a panel, and he was asked the question, and he was an obnoxious individual, number one. Right? But he said to me, look, he said to the audience, he says, I work for my shareholders. So I am raising the price so that my shareholders who invest in the company are doing well. And then he was asked, you've got an awful lot of negative publicity for raising the cost by 1,300%. Have you learned anything? Would you do anything different if you did it over again? And this is like the worst of drug company attitude. He said, yeah, I would make a change. I would raise it more. I'll never forget this. So I do believe that the government has to take a much tougher stand with, you could argue price regulation. You've got to be very careful, though, that you don't, and this is why I hesitate, that you don't eliminate the possibility for continuing, development of new drugs. Because you do need money to develop new drugs. But I do think the government has to take a very, very aggressive regulatory stand against them. Now, do I think it's going to happen? No. Not now. Because there are unbelievably two most powerful lobbies in Washington, in my book, are the NRA and the drug companies. They're very, very powerful. But I do think that they deserve to be regulated pretty strongly, while at the same time preserving the ability to do constant innovation and discovery, because you need to come up with new drugs. Now, there's another challenge to them, to the drug companies, and we're at the cutting edge of this. There are now implantable devices that you can implant in the nervous system of the body that can actually solve a lot of problems without the use of drugs at all. We now have demonstrated at our research center that you can put lupus, Crohn's, arthritis in complete remission by the insertion of a little device the size of a nickel on the vagus nerve in the neck. It's called bioelectronic medicine. This is a whole new era. Anybody here that would like a presentation on this, come to our research center. You'll see some of this stuff. It's absolutely earth-shattering. And so you're going to find there'll be other models of treatment other than just the use of continuing drugs. So, yeah, it will require a lot more regulation. I don't know exactly what form the regulation would take on. It's not an area that I spend an awful lot of time on. But some of the recent behavior, like even with the opiate issue, with OxyContin, I mean, it's like this stuff is ridiculous. I mean, people who do that kind of stuff, to me, they should be locked up. I have no patience for people who purposefully, for the purpose only of making money, knowingly put people in terrible situations. That's not appropriate. And some of these companies, have origins in Long Island.
Let me say thank you for your recognizing for all immigrant employees in Northwell. I'm one of them, and we're trying to fight for our life in here and trying to do all the best we can. So let me say thank you for you. Secondly, my question is, Northwell is serving as one of the most diverse community in the whole United States. So what is your opinion? What do you think about the language disparities when we deliver care and also when we promote in the community?
What was that? This is on the diversity issue? Yeah. We do exist. Queens and Brooklyn are two of the most diverse communities in the world. And delivering care to people from diverse communities means that you got to be able to understand those communities. So we encourage an awful lot of cross-education, cross-fertilization. I talk about it at orientation when I do the new employees. So you've got to understand where other people come from to be able to fully appreciate how it is you deliver care to them, because people's cultures are different, religions are different, backgrounds are different. We're working very, very closely with the Asian community, the Jewish community. We're very involved in Brooklyn. The Asian community in Brooklyn has exploded like you wouldn't believe. It's amazing. People from pretty much every part of the world that comes to us. So what we need to make sure of is that we have the staff that can deal with people from those cultural, religious backgrounds. And if we don't have the staff that comes from those places, that we have staff educated enough that understand. So one of the things I encourage people every Monday morning when I meet with all new employees is to look at the table that they're sitting in. And because at around every table, you'll have unbelievable diversity. So people have to take upon themselves the obligation to learn about other people. A lot of people wait for something to be done for them all the time. But if you are working in an ICU, for example, in the hospital, and a lot of your patients are from, Pakistan or they're from Haiti, you got to learn something about Haiti, and you got to learn something about Pakistan. You got to understand the religion. You got to understand something about culture. Different cultures have different views of health. Different peoples define health differently. You cannot at all deal with it appropriately if you don't understand those. So we're working hard on this. This is a long-term process to be able to do things like this. Providing care in those communities by people who are more attuned to those communities is also part of our strategy. A lot of our ambulatory sites are being created in those communities right now. I think it's a wonderful thing. I think this diversity is fantastic, by the way. I just love it. When I walk into the room and you'll have 50 companies represented, multiple religions, this is New York. This is the United States. This is just great. We'd all get a PhD a month if we learned something more about people we don't understand. And we also got to appreciate, as I tell employees all the time, that we all have inherent biases and prejudices. The person I worry about is the person who says, I'm not prejudiced. We all have it inherent from our backgrounds. And we have to acknowledge it and deal with it and say, I have to learn more about those other people because, quite frankly, I don't fully understand. The more you learn, the more you expose yourself to different views, the better off you will be as a human being, and definitely better off you'll be as a provider of healthcare. Language issues, yeah, we have multiple ways of dealing with the language issue, but that's part of it.
Speaking of which, diversity, we have a growing Chinese Asian population, especially in the New York area, and acupuncture, which I've had and is wonderful, is really, really resisted as far as the medical community embracing it and people going for it. If you don't have insurance that covers it, which most of them don't, then you wind up going to a doctor that might put you on medications instead of going for acupuncture, which will be much more economical to treat you. And yet there's such a resistance. How do you see changing that?
It's changing. In fact, I was smiling because I had a meeting on this morning. I had a meeting on acupuncture this morning. I had acupuncture myself. Because I like to try out different things, you know. I've had many surgeries. I like to do. No, I played sports big time one time, and so I had lots of injuries and I've had lots of surgeries. And I had acupuncture. Years and years ago, 25 years ago, I had acupuncture treatment. And it worked, at least for a long period of time. Acupuncture in our health system is used a lot more than what you think. But if you make it, if you were to stand up and say, I wanted to create a department of acupuncture, the medical societies, the docs and others, will really go crazy. Even though many of them that will go crazy will already be using it. Because there is this view, as I started out by saying, it is dramatically changing, very different than it was 5 or 10 years ago. Because people will argue there's no science behind it. But you've also got to understand that most medicine is not science-based. It's behavior-based, it's habit. About 80% of medical stuff that is done works because it worked before, and they learn through habit and through experience that this is what worked, therefore I know it'll work again. But being purely empirically based, there's only probably about 20% of it. So it's a kind of a fake argument, but they'll use it. There was a great story here years ago, Stony Brook years ago. I don't know if many of you remember this. They made a big announcement, and that thought was very progressive. They made a big announcement that they were creating a department of acupuncture. There was a revolt. And I remember when I heard about this, I said, bad idea. You gotta do it, but don't announce it in a big way. Now, we are going to become much more aggressive on acupuncture. And that's my meeting I had this morning. A lot more, most of my physician leadership that is around today are different from the physician leadership I had 10 years ago. I only have 2 clinical leaders today that were with me a dozen years ago. I've changed, everybody has been changed out. I have all new people. If you look at my chair of medicine, the chair of surgery, you go across the board for those, I do have employees, there's some employees here. The newer doc, much more open to the traditional people. So it's the same with chiropractic. It's the same, for example, I remember docs complaining to me that, some docs, that rehab was not something worthwhile investing in. Yet today, you will not find a good orthopedic surgeon that won't tell you that the way you really get better is to do rehab, even after they do the surgery, right? There's a sea change. Well, a couple of other things to keep in mind. The new docs coming out. We have a great medical school. The Zucker School of Medicine. We have a partnership with Hofstra. We just did we had a graduating class graduated on Monday. Our medical school is phenomenal. It's now nationally ranked. We're on the top places in the country. All of these young docs coming out have a whole different view of the world. They talk more and more about wellness and prevention. Technology scares the daylights out of the old docs. It's one of the things, if you meet in a group, have a room full of docs like this, the one thing they'll all complain about is technology, the electronic record. The new docs will design the records. I mean, they're so adept with technology. Over time, all you got to do, I say to people, stop complaining about EMR. Over time, it'll take care of itself because, the new people will adapt to it. The other thing that's changing is that the majority of docs coming out are now female. In Europe, in Ireland, 75% of all new doctors coming out of medical school are female. There's only 25% male. In fact, you could make an argument that they have a male affirmative action plan. Right? Because women will beat men anytime in standardized tests, right? So now what does that mean for healthcare long run? This is also, of course, when the bulk of your docs are female. You don't go back too far when you couldn't find a chair of a department that was female. Today, much more common, not the way it should be. That will change the whole tenor of how we have to operate. It will change the way we have to schedule work. The hours of work will change. pregnancy will interfere with the occurrence, with the schedule of work, therefore the work schedules will have to change. Will it add more humanism to the delivery of healthcare? You know, because, you know, the other thing that's happening is work is changing. The nature of work is changing. A lot of our employees now work from home. How we teach people is changing. The concept of learning is changing. Very few people want to sit in the classroom and want to listen to a lecture. That's out. In our medical school, we have no lectures. None. In our medical school, we have no multiple choice exams. None. How do we do assessment of our medical school students? Simulation. Just like the way pilots are trained to fly planes, we have the largest simulation training center. Education, for the most of us in this room, including me, education was about memorization. You study, you memorize. You memorize it, you go in and do your test. On the way out, after the test, you forget half of what you thought you knew when you went in. The whole new way of education is hands-on doing, teaching how to do, because you don't need to memorize anymore, you Google it. Right? So everything about the business, this is not just healthcare only, but everything about the business is changing. And the attitude toward things like, Eastern medicine, acupuncture, all changing. And much more positive receptivity today as a package of things that you need to do. And I was at a state running, I ran health and mental health and substance abuse, alcoholism and all. We used to use acupuncture for drug addiction. I had clinics where if you walked in, everybody was sitting in chairs with the needles in the ears. And we did research, and it worked. So with cancer patients, we use acupuncture a lot with cancer patients in the health system today. So it's all good. A lot of good things happen. The old ways are going by the wayside. And those of us from the baby boom generation have to let those new attitudes just percolate. We can't stop it. Sometimes you stop it because you're insecure. You want to protect what you've got rather than allowing new things to emanate. So it's all good. Healthcare over time, I think the biggest improvement in healthcare long term will be self-improvement, people doing it themselves. I mean, when people take responsibility for their own health and get more focused on it, stop drinking Coke, stop taking in sugar, watch what you eat, that will reduce healthcare costs long term, and that's what will improve health. It's not just what the doctor in the hospital does. We just take care of you, for the most part, after you get sick. And 80% of ill health is due to behavior, lifestyle, and where you live. Where you live determines how long you live. In New York, there is up to a 9-year difference in longevity between one community, a poor community, and a non-poor community. You live in a good neighborhood, you live longer. Those are the things, but it's what we do to ourselves that makes the huge difference.
So I'd like to expand on that with you, but my question has to do with returning to the issue of cost.
Yes.
Because I think you really glossed over that from the point of view of the hospitals. But I'd like to ask, because it makes no sense to people when you see the insurance, right? And you see what the doctor asked or the hospital asked, and you see what the insurance pay. There's like no sense to it, no rhyme or reason. And you've just said you employ 4,000 people to fight with the insurance companies. The Trump administration's big idea this past week in terms of addressing healthcare issues was to say, we want a shopping market. We want to require hospitals to publish their rates so that people know in advance what it's going to cost them, as if people have the ability to shop around. But I'd like to go back to, how do you see getting to a fair cost so that it shouldn't be such a difference if you have insurance or not, that there's this, like $1,000 versus $200.
Well, yeah, but the trouble is one is the reporting of this. I mean, poor people are not charged more than non-poor people overall. It's not at all. In fact, definitely not in our system. We are required by the federal government to post charges, right? Which is a fake thing, honestly. I wish we didn't have to do it at all, but we got to do it, and everybody jumps on that and says, oh, look what they're charging for this. It has no bearing on what I get paid. None. Now, the Trump administration, there's a big article in today's Wall Street Journal about this. They basically want the healthcare systems, hospitals and all, to tell you what the cost is before you go in. Impossible to do. Impossible. It would be like calling up the restaurant and say, what's the cost of the meal? The restaurant says, well, what the hell kind of a meal do you want? Or calling up the car company and saying, what's the cost of the car? I don't know. You want a BMW? You want a Kia? You come into the hospital and you have a condition. I haven't got a clue what your condition is until we go and we do the diagnosis and the examination. And then let's say I do surgery. I had a case of a friend of mine today, had surgery, found out after they did surgery of cancer, that the cancer has spread to another part of the body. They did the surgery on one part, they got to bring it back again for the surgery in the other part. I haven't got a clue what this person's problems are before that person comes in. There's no way to give you a price on this. Now, in our system, if you come in and we are able to tell you pretty much what your out-of-pocket costs will be for a lot of the procedures, especially the simple ones, like if you need a shoulder replacement or a shoulder fix or a knee replacement. They're relatively simple, assuming there's nothing else wrong with you, okay? But for the most part, you're never going to be able to disclose the cost because I don't know what it is you have until after I do all the tests. It's impossible. People come in thinking of one thing. I had one of my employees go in, his wife had a back pain. She goes in to have a check. What was the problem was not her back, she was full of cancer. She's in the hospital for a week. They did major surgery, multiple surgeries. She died. How's anybody got to know before you come in that was the problem? Can't. So it's simplified. Do I think there has to be some more price transparency? So, for example, a patient knows before they come in, based upon what their insurance is, that if they do the following and under these kinds of circumstances, this is the out-of-pocket cost. Yes, we should be able to do that. And we do a lot of that today. But this overall thing, I'm going to just, it's like shopping for a car or shopping for a clothes. It's not the same. There's no comparison at all. Now, they do simple things like if you go in for an MRI test at this place and you go in over here, there might be two different prices. The question's asked, well, why are there two different prices? Now let me explain. If you go into a private group over here that has no obligation for anything other than managing that group, they'll charge you $100. If you come to us, I charge you $150. Why? Because I also are running psychiatric hospitals, and I got to make a little bit of money there to cover the psych hospitals where I get no money or very little. It's the totality of the situation that complicates it. I do think that the overall costs, hospital costs have been stabilizing. It come down a little bit over the last couple of years. But I do think that it runs, if we get the inefficiency out, you'll be able to control the rate of increase. But in terms of overall cost, I don't see it coming down below the percentage it is of GNP right now. I think that's a fallacy. And politicians are out there saying that, I just think they're lying to the public. What I would like to see, however, is that you'd be able to tell you what your out-of-pocket cost is. I can't tell you what the total cost is because I don't know what your situation is. But based upon insurance, I should be able to tell you what you have to pay out of pocket. And by the way, in most surveys we do with patients, that's what they're primarily interested in, what comes out.
We're going to, let me just say that we want to thank our guest very, very much. We're going to have two more questions, and then we will enjoy ourselves inside with some cookies.
That's for health reasons. That's for health reasons. By the way, if you want to improve your health, don't eat the cookies.
Mr. Dowling, I'd like to go back to your original comments about what our responsibility is, our share of our health,
Yeah.
that may be out of the hospital system. I'll give you an example. She breaks her hip, she goes to rehab, Medicare gives her 30 days of physical therapy. Outside of that, is there a parallel system? Is there some place we can go to maintain her health, whereby the insurance doesn't cover it, it's not a medical problem, but it's something for her longevity, to keep her active, to keep her moving? There are no places, there's nothing available. Is there a parallel system that maybe the government or the medical field should develop so that we can maintain the health?
Irrespective of, is it not a cost issue, right? It's,
Well, yeah, in our case, when you get old, you get a limited income, you
Yeah,
have a cost
sure.
issue.
There is no system that the one as I think you're describing that it exists. What we do in situations like that a lot is that we take care of the person ongoing anyway, whether or not there's any cost associated or not. We will continue to provide the care in many cases. But insurance will cut you off after a certain period of time. And after that period of time, whether it's Medicare, Medicaid, or private insurance will typically cut you off after a certain period of time.
Right, and then you're on your own and there's nothing available.
Yeah.
There are no facilities, there's no place to go with a walker or anything to keep them mobile, to keep them active.
Keep them active and mobile, yeah. No, you're right. You're right.
Okay, our final question.
Mr. Dowling, thank you so much for tonight. You've spoken about coverage versus access a little bit earlier tonight, and you've given some points about coverage. I want to talk a little bit about access. What are strategies that you have implemented or strategies that you have seen throughout the country that works to improve access for patients, not just with commercial payers, but also with the non-insured population as well? I'm from New York City Health and Hospitals.
Well, one of the ways that we've tried to deal with it is to develop a distribution network of services all over the place. So this is where you can't travel more than 3 or 4 blocks any place around here. Seeing one of our locations. So we have created 700 extra access points in the region that did not exist 10 years ago. So you don't have to go to North Shore Hospital to the emergency room unless it's very serious. You go into one of our 60 urgent care centers. We have multiple cancer facilities all over the place. So the whole idea is to have a broad distribution network so that it's more accessible to the people, so you don't have to travel distances. So I'll give you an example. Southside Hospital, which was a hospital that was dying, and people out in that part of the island, they used to have to come to North Shore to have open heart surgery. Families had a big, it doesn't seem like it's far away except when you get stuck in traffic. So we moved open heart surgery out to Southside. We opened up open heart surgery at Southside. So now the people in that area can actually have open heart surgery at Southside. In fact, it's the biggest open heart surgery place today in Suffolk County. So you don't have to do that travel. You don't have to go into the city now there's hardly anything you have to go into the city for that is not available on the island today, which was not the case before. So that's one of the major ways that we have been focusing on trying to improve access, educating people about it, telling them where to go, etc. People still go to the emergency room for things that they shouldn't go to the emergency room for because it's a cultural issue. It takes a long time to change. Despite the fact that I opened up 60 urgent care centers, including people, some of them like less than a mile from North Shore, many people will go to the urgent care, but still an awful lot of people who should go to urgent care will still go to the emergency department. That's an educational job over time. People still think emergency department should go there. Over time that changes. And that's happening around the country as well. So it's providing more locations. Yeah, and the problem when I was going back to Ireland again, part of the problem I have is that they're locating all of the major care in Dublin. So if you're living 2.5, 3 hours, 4 hours away, you'd have to go into Dublin for care. My argument is move the care out of Dublin, out into the western part of the country so people don't have to travel all that distance. People have a hard time with that. We've moved them out. Moved them out. More access will now be happening through technology, telemedicine. We'll all be using telemedicine within a couple of years. And so psychiatric care we do now through telepsych. People, and by the way, people are much more comfortable with a mental health problem talking to a camera in many cases than they are actually meeting in person with the individual psychiatrist. Because we don't have enough psychiatrists at all. And mental health is becoming a huge issue, so we do it through this. In the last 9 months, we've had 11,000 telepsych treatments, access. So this will improve access. Not for everything, but for a lot of things, so you don't have to travel. Today we can look, we have one central location for intensive care, we can look in at every intensive care unit at every one of our hospitals from one central location. We can talk to the patient, we can talk to the doctor from one central location and make decisions based upon the interaction from one place. The same with stroke care, etc. So there's a lot of things happening in that regard. But you're dealing with cultural attitudes, changes, people. I still, to this day, I made my own mistake. I cut my hand at home, I went to the emergency department. I'm sitting in the emergency department and saying, what the hell am I doing here? Like, I forgot. It's like, I said, oh, I drove by 2 urgent care centers. Because mentally, it's like emergency department. Takes time. Okay?
Well, I want to thank our guests very, very much. Thank you so much.